Well, thank you for joining. Sorry, we've just. Okay. Thank you for joining our special seminar this Monday on menopause and the mind, understanding brain fog. My name is Anna Pelagi. I'm the program lead for aging and health systems here at the George Institute for Global Health. I'd like to start by acknowledging the Bidjigal people as the traditional custodians of the land on which we're gathering here today in Randwick, and to pay my respects to elders past and present and extend that respect to any Aboriginal or Torres Strait Islander people joining us today. And we've got a nice group in person in the room, and I understand we've got people online as well. So it's really my pleasure to be able to introduce to you Professor Aimee Spector. Aimee is Professor of Clinical Psychology of Aging at University College London. She developed cognitive stimulation therapy for dementia within her PhD, which is now the primary non-pharmacological treatment offered in the UK National Health Service and implemented globally. Aimee directs the International Cognitive Stimulation Therapy Centre at University College London, and this involves working with 42 countries and supporting cognitive stimulation therapy training centres across Europe, Asia, the US, New Zealand, and now Australia. Her expertise lies in the global development and evaluation of complex interventions for ageing. And she also directs the UCL Menopause Mind Lab, a research group focused on the impact of menopause transition on cognition and mental health. And Aimee will be sharing her experience and expertise in this area with us today. So it's my pleasure to introduce Aimee. Thank you.
Thank you. Thank you. Thank you so much for inviting me. It's a real pleasure to be able to talk today on my new topic of interest, cognition and menopause. So I'm going to be very self-disclosing now, and it says that the audio's off. Can people on the Zoom hear? They can. Oh, perfect. Brilliant. Thank you. And why I've ended up doing research in this area. So I've been working in dementia since the late 1990s and very focused on dementia throughout my career, but had a very strange experience myself in my early 40s when I noticed really big gaps in my cognition, particularly in ability to find words, which happened just then, and verbal memory. And I was really, really worried about it. I talked quietly to a few colleagues, although of course these things are quite embarrassing, and went to my GP, and I was quite close to having an assessment for dementia. And it took quite a few years to realise that there was a potential hormonal link. I realised that when I went on hormone therapy, and I was really, really shocked that I, as somebody who worked in dementia for all those years, hadn't known about these cognitive challenges that may happen in midlife. My GP hadn't known anything about it, and nor had colleagues. So that kind of encouraged me to delve into the research and look at what was out there and develop the Menopause Mind Lab, because I realized there was this huge gap in terms of knowledge and implementation. So why is this important? I think people really want to know. So every time I've talked on this, there's been a big show of people, and actually I think it's a real focus, a potential focus for research as well. So in the UK, we have the NIHR, which many people would have heard of, the National Institute of Health Research. So they're our main funders for research. And they run something called the James Lind Research Priority Setting Partnership, where they ask people who are clinically experiencing the problem, so in this case menopause, to come forward and talk about what they think we need to prioritize in terms of research. So they did this in 2024, and the group came up with 40 research priorities, and number 3 out of 40 was, does perimenopause or menopause lead to cognitive problems such as brain fog and memory loss? And if yes, why and how does this happen? How are these problems best detected and managed, and can they be prevented and or reversed? So people really want to know and understand this. Another thing that's very current is something called the Menopause Mandate Survey. So in just this year, a few months earlier, there was a very large campaign group in the UK that we've been working with, who did what they called a mega survey. So they surveyed over 15,000 women in the UK, asking them various questions, and one of them was to record their symptoms of menopause. And people were allowed to record as many as they liked. On average, people had 11.2 symptoms, but by far the highest symptom reported was brain fog. And so this came out at 86%. And it was really interesting because hot flushes were 54% and night sweats were 53%. And these are the symptoms that we tend to associate with menopause. But actually, what people were saying is it's the cognitive symptoms that we're really struggling with. So it feels like it's very important. Just a bit of background. So, what is menopause? Many of you will know, but sometimes the terminology is not always clear. So it marks a change in reproductive capacity for people, typically in midlife, and it affects everyone with ovaries. So women and also some trans men and other people who don't identify with women, but anyone with ovaries will go through menopause. So we first think about the perimenopause, which is the period which can go up, sometimes lasts for up to 10 years, which is when the menstrual cycle changes a bit, where people are still having menstrual periods, but they tend to be disruptive, less frequent or more frequent, heavier or lighter. And often people have most symptoms at this time because the hormones are the estrogen and progesterone are fluctuating very much up and down at that time, which we think leads to these difficult symptoms. Then the menopause itself is actually one day in the person's life. So menopause describes the time when 12 months after the final menstrual period. So it's that one day where you've reached 12 months. It's in the UK it's 51 years, and generally with Caucasian populations, on average age is 51. But what's really interesting is that age is slightly different in different ethnicities. We don't really know why. So we think that Black, Southeast Asian, and South Asian women have slightly younger menopause. It's normally around 47 or 48. And then post-menopause is for the rest of the woman's life. So they may continue having symptoms for some time, but they tend to settle down after a few years or sometimes quicker because the body settles into this new hormone levels. So, what is brain fog? Well, I think the first thing to mention is that cognitive symptoms of menopause are not well defined either subjectively or objectively. And the term brain fog is vague and it's used for various other things. So, we were talking this morning about post COVID brain fog or brain fog post chemotherapy, etc. So, or even baby brain. So, it's a very vague term, but Pauline Mackey and Nicole Jaff came up with some good definitions within menopause. They said it describes a constellation of cognitive symptoms during the menopause transition, most frequently in memory and attention. And also that the severity differs considerably across women. So many people won't have any brain fog at all. We think about 86% have it to some degree, and we think maybe about 10% really, really struggle with it. So that's a very, very rough estimate, but that's what we see. So symptoms can include poor memory, difficulty concentrating, mental fatigue, difficulties planning and organizing, making decisions, and multitasking. And for most women, the good news is that the difficulties are temporary. So, they tend to settle down post menopause. But we do think that for those women, about 11 to 13% are clinically significant, which means that if you give them tests of different cognitive functioning, tests of memory and immediate memory and delayed memory and language and things like that, their scores really, really drop into from the kind of what we call the normal range to the clinical range. So they will be struggling. I've been doing some work with someone called Caroline Gurvich, who's doing some great work, and she's in Australia in the Monash University in Melbourne. She's a neuropsychologist, and we came up with a proposed definition because we felt like the definition was a little bit vague of brain fog and menopause. So we proposed self-reported impairment in one or more cognitive areas, so memory, attention, organisation, problem solving, or word finding, in the absence of a significant objective cognitive decline or impairment. So it's different to dementia. It can fluctuate, for example, daily or within the person's menstrual cycle and cause mild to significant distress and impact on quality of life, but it does not result in sustained changes in capacity to perform activities of daily living. So it is different to something like dementia. And I wanted to share this because I remember reading this when I first, in 2021, when I realized that I had brain fog. I didn't even know that the term existed at this point. And I came up with this paper by Mackey and Webber, which reported a number of longitudinal studies looking at cognition in women over long periods of their life. The first one there was actually published in 2006. So this is stuff that had been around for 15 years at that point. And what these studies, they looked at all these different cognitive domains, and the ones that are in red are the ones that came out as clinically significant for some people. So we can see verbal memory, verbal learning. Lots of people really deteriorating during perimenopause on those measures, and also a little bit in terms of processing speed and language and attention. So as I said, these generally people tended to get better post menopause, but I suppose what really shocked me is that this information was out there, it had been done, but it hadn't got as far as doctors. I think the other thing that became apparent at that point was that less than a third of medical training in the UK even had menopause within the curriculum. That's been addressed now, and it's much higher. But things like cognition in menopause is just not a topic that people are aware of. But yet we know it's a big clinical problem. I've got a fantastic PhD student called Lexi He, who's unfortunately we couldn't persuade to come to Australia, but she's written a review on the cognitive domains influence in menopause transition, which is in press at the moment, and here covers all the different domains that you potentially see. And the ones that are in dark red are the ones that we have most evidence are affected by menopause. And it moves across to the right, the ones that are least effective. So again, verbal memory, verbal learning, processing speed, things like that we're consistently seeing across studies are affected by menopause, but less so things like visual memory and auditory skills. I'm going to skip the next slide, but I think the slides will be available to people. That's just a definition of those different domains. So Caroline Gervich came up with this lovely picture, but it's just really thinking more broadly about why we think the factors that might be associated with menopause cognition. So when we talk about neuroendocrine changes and reproductive hormone changes, we're talking very much about the hormones, the biological side, but we also know that there are lots of other broader things that are affecting cognition in menopause. So we know aging, for example, for men and women, as we age, our cognition gets worse. I think there's evidence that every decade that goes on, our memory is slightly weaker. So aging is obviously a factor. Depression, anxiety, psychosocial stress, sleep, vasomotor symptoms, I'll come on to those separately, but they're all going to have an impact on our cognition as well as the hormone changes. And sometimes it's a little bit about disentangling and trying to understand what's causing the problems. So in terms of the biological side, and this isn't my area of expertise, so I can't take any complex questions on this. But what we do know is that there are estrogen and progesterone, which are the main female hormones that change during menopause transition. We know that there are receptors within the brain. And that they're found in high densities in certain regions of the brain that are involved in cognitive processes. So the hippocampus and the prefrontal cortex, we see a lot of these receptors. And there have been some studies in rodents where they've used models of surgical menopause, where you remove their ovaries, poor rodents, to see what happens. And they found that that you can really see a very clear link between estrogen and brain plasticity, regeneration, and blood flow. So these you can very clearly see these processes in rodents. The human studies are a bit more mixed. So some of them show correlation between estradiol, which is the main type of estrogen, and memory and attention during peri and early postmenopause. Some don't. But what's quite interesting is the studies of surgical menopause, when you remove people's ovaries. So often that happens for people who are younger, who haven't reached natural menopause, and there are some links between removal of ovaries and decline in memory and processing speed. So we can definitely see that association. So you kind of assume from that that giving people menopause hormone therapy might improve their cognitive functioning. That kind of hypothesis would stand and make sense. But actually, the results are really, really mixed. So there have been 4 big trials on menopause hormone therapy. That's MHT, is menopause hormone therapy. Sorry, I should have spat that out. And they show kind of neutral effects on cognition, which is in some ways puzzling. But one of the really clear things that we can really see is that a lot of these trials looked at women who were older, maybe over 65, and we think that the critical window for giving people hormones to help their cognition is maybe at younger ages when they're going through perimenopause. So that might be why they didn't pick up changes. I think another problem is that they don't measure cognition very well. So a lot of the tests that people are given are for dementia, and people aren't really people are scoring sort of top marks before and after because they're not sensitive enough to pick up these subtle changes. So other things that might impact on cognition. So we know there's a paper, a review there by Zhu et al., which looked at cognition in perimenopause and some of the risk factors. We know that socioeconomic factors can impact on cognitive symptoms and all symptoms of menopause. So things like income, employment, education, living conditions, life events, stressful events. And also lifestyle factors, so smoking, drinking, diet, exercise, caffeine, and BMI. We know that these factors affect most areas of health and mental health. So that kind of follows that symptoms will be worse in people who have adverse conditions in terms of lifestyle and health. We see a very strong link with depression and working memory, verbal memory, subjective memory, and psychomotor speed. And I'll come on to depression in a minute in a bit more detail. We also know that there's a very strong link between poor sleep and memory, consolidation, attention, and executive functioning. And I think we can all relate to this. If you've had a very bad night's sleep, your brain's just not working properly the next day, is it? And, our attention is going to be very much switched off. There are ethnic variations in symptoms, which is interesting. So I mentioned that the age of menopause varies between different ethnicities, but also the way that symptoms present seems to be different. Research is very weak, so it really needs to be developed. We know, for example, that white, non-Hispanic women reported more brain fog related symptoms than Hispanic and non-Hispanic African American women. And non-Hispanic Asian women reported the lowest severity of brain fog. And one of the things we're looking at the menopause mandate analysis is how symptom profiles differ in different ethnic groups. But we know, for example, there's very strong evidence that Black women experience the highest level of vasomotor symptoms, which is the hot flushes and night sweats. We don't know why, so that's really interesting. And we also know that more severe brain fog is associated with older age during menopause, being non-married or partnered, or having low parity, so fewer or no children. Just going to have one sip of my coffee. So in terms of depression, last year we did a meta-analysis where we combined data from 17 studies and over 9,000 women. We were trying to understand, using a very large sample, the link between depression and stage of menopause. And we found that perimenopausal women are at significantly higher risk for depressive symptoms and diagnoses compared to premenopausal. Premenopausal being at the age where you're still in the reproductive years. And this was a nice paper because we had a really diverse sample, which is quite often hard to find in research. So the sample included white, African American, Asian, Hispanic, Chinese, and Japanese samples. So very, very clear link between depression. It seems to be a period of vulnerability, and we've actually repeated a very, very similar study, which is under review at the moment, looking at anxiety and at the different stages. And again, we found perimenopause to be a period of vulnerability for anxiety, and this is matched in other studies as well. We also know that mood and cognitive problems are very much bidirectional. So, if you imagine, if you're very anxious about forgetting things, you're more likely to forget them. It happens to me all the time, particularly forgetting people's names. So I think I had that this morning when I had to introduce 3 people whose names, of course, I know, but then I was like, going to forget their names, and so we can really see that link about how that works. Also between physical and psychological symptoms. So we know, for example, there's a very strong link between hot flushes and anxiety. If people are worried about having a hot flush, the anxiety makes a heart rate faster, often makes us sweat a little bit, and you can really see that link. And then you have the hot flush, and then you're worried about what people think, and that makes the hot flush worse and makes the anxiety worse. And same with sleep and depression, that you feel your mood feels low because you haven't slept, and when you feel depressed, you might wake up in the night and have very negative thoughts. So very, very closely linked. But I thought I needed to say something positive at this point, because everyone's probably thinking, oh my goodness, where is life going? There's somebody called Dr. Sarah McKay, who's actually in Sydney, and I met her yesterday. She's a neuroscientist and has written a book called The Woman's Brain Book. And she really tries to paint a more positive picture. She said, I asked her why yesterday, and she said, I'm fed up of all this negative stuff about menopause all the time. We need to think about the positives. And she talked about she talks about 2 things: crystallized abilities, which is our ability to use knowledge, facts, and learned information that has accumulated over time. So our learning and wisdom as we get older. And also our cognitive flexibility, so our capacity to adjust thoughts and behaviors in response to change. And says that both of these are greatest in midlife compared to younger adults, when I guess you're not as wise, and older adults when you maybe get a little bit more fixed and set in your ways, and are nervous about being too flexible because of sort of anxiety. So we're at our kind of peak in midlife of these 2 things. And she said that as we age, our brains trade cognitive speed for richer, more efficient problem solving and nuanced decision making. And anyone here in midlife, I can really relate to that. Sometimes I'm a bit slow in thinking about things, but then when I process it, it feels more sophisticated than maybe that quick thinking that I did when I was younger. And we get better at spotting patterns, weighing options, and making smart decisions that draw on experience. So one of the big questions, I think, is how does brain fog differ to dementia? And I think Caroline Gervich and I published this a couple of weeks ago, and I've shared it on social media, and I've had a lot of people feeding back like, that's really, really helpful because I thought I had dementia. And I also think clinicians don't really know how to make this judgment. It's very, very much a growing area. We just put in this table our initial thoughts, but I'm doing some research at the moment with a doctoral student trying to develop a more sophisticated tool that can support clinicians in differentiating or working out whether this person actually maybe would respond to hormone therapy or a bit of reassurance or some sort of cognitive support, or whether they need to be referred for more extensive assessments for dementia. So the sort of basic is who it affects. We know that dementia affects men and women, and it's more common for over 65. So obviously menopausal brain fog is for women in that age group. The course and progression as well. So both can have a sudden or gradual onset, but the way it looks over time is different. So with dementia, you tend to, that's why I talked myself out of a diagnosis, because it'd been going on for 3 or 4 years, but it hadn't got any worse. I think with dementia, you do expect over time things will deteriorate. And also you see a fluctuation often with menopause brain fog. So it may be that certain days in the month it's absolutely terrible, and other days it's okay, or even time of day, it's some time of day it's better than others, which you don't necessarily see in dementia. The symptoms of dementia are much more complex than just memory loss. So you often have much more higher cortical functions. Have change in social behavior, motivation. People often have problems with language, coordination, things like dressing themselves and such like. Um, Brain fog I've already defined, but it's difficulty recalling words and numbers and daily life and forgetting things, basically. Dementia has a mild to severe impact on daily living, whereas menopausal brain fog doesn't impact on daily living, but may well impact on quality of life and may lead people to change their lives, for example, by not working or doing things differently. And who notices is also relevant. So often with dementia, people don't notice themselves. There's sometimes often a lack of awareness, whereas with brain fog, it's I think women tend to be quite self-critical and think it's worse than others do, and often others don't pick it up. And in terms of effective screening, there's various validated measures for dementia, such as the MOCA and the mini-A's. There isn't a recommended battery of testing for brain fog, and it's not something that can be diagnosed. But there's various things in dementia that are used, like the clock face task, which you're very unlikely to pick up any change on if it's brain fog. So, just in terms of the workplace, I think I'm not sure if there's data in Australia, but certainly in the UK, there's increasing awareness of the impact of menopause on the workplace. Um, so, the menopause mandate survey that I mentioned, 77% of women said that they were negatively impacted by menopause symptoms at work, which was higher than impact on relationships at 71%. And another report came out in 2022 saying that 1 in 10 women will quit their job and 1 in 4 will reduce their hours during menopause transition. So that really led to people were a little bit shocked about that. And I think that, and also that women, another survey that said that women aged 45 to 54 um, report more work stress than men or women of any other age group. So this led in the UK for the government to have what they call a menopause SAR, which is somebody whose job is to get the over 50s back to work, because we're realising the economic impact of people going through menopause transition. Okay, so in terms of management, I think in terms of what clinicians do, I don't know if we've got any clinicians at this audience, so I'll just, but these are the kind of questions that link, I think, to the earlier slide on thinking about dementia. So, have you noticed changes in your ability to concentrate? How long has this been going on? Does it worsen after sleep? I mean, this is really important as well, because we do believe a lot of people think it is just related to sleep. I'm not so sure about that, because when I've had brain fog, it hasn't linked to my sleep, but certainly sleep and mood changes are really important. Does it coincide with menstrual cycle? Has your work or daily activities been affected? Have you experienced any significant life stressors? So I think when clinicians are evaluating this, if they have time, which we've talked about already, I think doctors don't really have even time to ask these questions. They do need, should take it seriously and rule out other medical conditions, nutritional deficiencies, and psychiatric conditions that could contribute to or exacerbate cognitive symptoms during midlife. But in terms of strategies, so menopause hormone therapy is usually very helpful if women experience problems with hot flushes and night sweat. So those are what we call the vasomotor symptoms, and that's where the evidence base is really good for hormone therapy. And it definitely has a good evidence for mood and sleep as well, which we think will help cognition. So although we don't have direct evidence of hormone therapy on cognition, all these other things that it helps. If you're not having night sweats and you're not therefore waking up in the night, that's going to probably make your brain work better. There's no robust research evidence to show cognitive changes, but research is needed. So that the evidence that's out there, as I said, is very poor quality. And there is an anecdotal link with testosterone and brain health as well. So that, again, no published clinical trials, but lots of people, and I think there might be a trial going on at the moment, I'm pretty sure there is, thinking that maybe testosterone supplements may help brain health. At UCL, we're developing an intervention to help people who are struggling cognitively, particularly people who are to keep women in the work. We call it CST Meno, which is cognitive stimulation therapy for menopause. And it's a combination of psychoeducation, cognitive strategies, peer support, and cognitive behavioral therapy. So, psychoeducation is just explaining what's happening in the brain. And I think actually just understanding that it's not dementia and normalizing it a bit for many people is very good, and having strategies to support yourself, etc. And peer support, just in terms of being in a group and hearing other people going through the same thing. We think that exercising the brain is really important throughout life. Some people say do crosswords or practice word games, but I think it's really about just keeping the brain active, and also things like improving sleep, healthy diets, and physical health. So, cognitive behavioral therapy focuses on how we link our thoughts, feelings, and behavior. And apologize to many people will know this already, but I think it's really relevant when you're thinking about some of the symptoms of menopause. So, in our CST Meno, we'd say, what runs through your mind when you draw a blank and you're in a meeting, and you think that you've forgotten everyone's name, and what do you think is going to happen, and how do you feel, and what you might do. And there's a very nice book called Coping with Menopause, which is written by, there's a reference there, that written by a clinical psychologist in the UK who talks about using CBT and other tools to manage menopause symptoms. And she gives an example of a CBT vicious cycle when you have, and her example here is having a hot flush during a team meeting. And the physical sensations of burning sensation in the face and the chest and the sweating, the very unhelpful thoughts that everyone's staring at me. This is so embarrassing. I can't actually read this because it's too small, so I'm just guessing it. Everyone's staring at me. It's really embarrassing. I'm never going to be invited back to this meeting. They're not going to take me seriously. I'm going to lose my job. All these very, very negative thoughts. Then the emotions of sort of sadness, anxiety, fear, distress, and then the reaction may be, I don't go to that meeting or anymore. If I go, I'm really anxious before I go, or lots of sort of safety behaviors and things like that. And then she talks about a coping cycle, which is basically flipping it on its head and really trying to change your thoughts. That's what we do with CBT, because the idea is if you can think about things in very different ways, it impacts our behaviors, our emotions, and our sensations. So you have the hot flash, and your helpful thoughts are, no one's even noticing. If they are noticing, they probably think I've just been to the gym or I've just been outside, and they're probably too busy thinking about everything else, and I'll just take a few deep breaths and it'll be fine. And then the behaviors are, breathing deeply, just looking down, letting it pass, balance emotions, and the physical sensations potentially calm down. And there's a good evidence base for CBT for hot flushes and night sweats. And it doesn't necessarily, CBT doesn't necessarily get rid of them, but when people's appraisals and beliefs about them are much more positive, the distress caused by them and the impact of them is much better. So I do think a lot of how the other thing just to mention is that we have guidelines, nice guidelines in the UK, which I think people here are aware of, and CBT is recommended as a second line treatment after hormone therapy, which is the first line treatment. And a lot of people were feeling when that came out recently that's undermining the physical, what's happening physically, and saying it's all in the mind. And I think I'd argue it's not saying it's all in the mind, but it's saying that it's a completely physical sensation. But I think with our mind can make physical sensations better or worse. That's the bit we can control, and that a lot of people need both hormone therapy and cognitive strategies as well. So just a few other things in terms of managing brain fog. So this is a little table that I put in a book chapter I wrote called "Am I Losing My Mind?" About brain fog. So just a few suggestions: avoiding distractions. So there's a lot of, we all have this, don't we? We're looking at we're doing something, we're in a Zoom meeting, probably some people listening now will be doing this, and there'll be emails flashing through and text messages coming at the same time. So have less clutter, optimize your scheduling. So try not to have back-to-back appointments, try to do cognitively demanding things at the time of day that's best for you. Use visual association when you can. So I think a lot of so much of memory problems are due to poor attention because we're doing too many things and we're not concentrating. And so I just give an example there that you'll be introduced to lots of people at once and you'll forget everyone's name. So when you're looking at someone, try and think of something visual that will help you remember. So if you're introduced to someone called Cara, imagine her driving a car. But rubbish example, but and use compensatory memory aids, so diaries, mobile phones, setting timers and things like that. So that brings me to my last slide, which is just to say that we've set up the Menopause Mind Lab at UCL, and there's a link there to the website. It just summarizes some of the projects that we're doing and opportunities to take part. And any questions? I can't see the time on there. I'm not sure if I've got time for questions even.
We do have time for questions, but thank you. Please join me in thanking Aimee. So yes, we do have 5 or 10 minutes for questions. Actually, we might start with questions in the room and then we'll go online. And if you're online, please use the Q&A function to enter any questions you might have for Aimee.
Thank you. That was really interesting. My name is Simone and I head the food policy team, so I have no clinical knowledge whatsoever, but curious whether there's been any mechanism by which ADHD medication might help with brain fog.
That's really interesting. I mean, I think it's very much an emerging field. So a lot of people are saying that brain fog and ADHD have very, very similar presentations, and there's a research group in the UK who are trying to work out whether ADHD diagnosis spikes in this population. I'm not sure that there is evidence because I think ADHD diagnosis is going up in every group, isn't it, in every age group, or whether people have masked ADHD symptoms for a long time and suddenly they have all these hormonal changes and these other pressures and it just sort of sets things off. So I don't know about whether you'd use so you're saying would you use ADHD medication in people who don't have ADHD but maybe are struggling with brain fog? I'm not aware of any research, so I don't know. I'm not sure. It's an interesting idea though.
Thank you. It was an excellent presentation. I just wanted to ask, is there any correlation depending on your education level that it's more or less, or the type of job you are in, academic versus non-academic?
Yeah, so that review that was done by Vanessa Zhu et al. That was there, which talked about risk factors. Education was in there. So I think that's quite a nice paper in terms of looking at all the different factors that might impact on cognitive impairment, and sort of low education and also employment status and employment group did seem to have some connection with brain fog and would also with dementia as well, which is interesting. Yeah.
Once you go through the perimenopause phase and then you're in menopause, does your cognitive function improve at all, or does it continue to decline?
So there's certainly the longitudinal studies suggest that things level off, and for most people they go back to where they were in post-menopause. I mean, then you get the additional impact of general age-related memory decline and increased risk of, sorry, it all sounds very negative, doesn't it? Dementia risk goes up and things like that. So I think, again, it's really poor research, but I think it does look like it probably does get better. I think one of the big problems and the thing to be mindful of is that people get the right support, though, because what you do see, if you think about those 1 in 10 women who stop working because they're not managing, whilst biologically or sort of hormonally things might settle down, if you've stopped working, you're not being stimulated, you potentially lost confidence, you potentially feel disempowered and can't do things. So actually that could lead to a bit of a negative cycle of impairment potentially because of that big lifestyle change. So I think giving people the right support is really important for that reason.
So I was wondering, like, it sounds like there's a lot that we still don't know. What are some of the most important questions that maybe you are researching or that the field is trying to answer at the moment?
Oh gosh, that's a good question. I mean, I'm really personally really interested in why some of us are more susceptible to this than others, because we all have hormonal receptors in our brains, but some of us seem to be much more sensitive to them than others. So that's really interesting, and I think, I mean, certainly people want to know who it affects more. Although that said, would it change? I mean, for me, I think having some kind of treatment is really important. So that's what we're doing. Because and lots of people who are seeking treatment are on hormone therapy but still struggling cognitively. So having treatment and support is really important. I think the questions around ethnicity are really important as well, and there's a big gap there. So we don't necessarily ask the right questions or have the right measures for a lot of, I mean, this is a very broad, this is in all areas of research, but just as an example, so I've got my Chinese PhD student who's developing a measure of subjective cognitive change in menopause in the UK, and she's also translated it into Mandarin, and we're using it in China. And actually what we found is that the way that we ask the questions get interpreted very, very differently. So it's on a 5-point Likert scale where it goes from always to never, with something in between. And the focus groups you ran in China, people said, well, I'd never say always or never, because you never say because it's either suspicious or you just don't want to. And lots of people have agreed from other contexts, whereas I think in the UK people would say always or never. They wouldn't really think twice about it. I think lots of people would. So we're often taking things that we've created in one country, using it somewhere else, and then saying, well, things look, the prevalence is different or the symptoms are different, but maybe it's something about how we're measuring these things that we need to adapt as well. So yeah, lots of things that we need to know about.
Yeah. Oh, thanks, Aimee. That was really, really cool. You kind of touched on my question already, but given that there's ethnic differences for brain fog, did you see anything in the meta-analysis for the vasomotor symptoms as well, like hot flushes? Were there any ethnic differences?
Yeah, so there's quite a lot of, there's definitely some research out there on hot flushes and how they differ. And I've got a doctoral student doing a meta-analysis on that at the moment, actually, looking at cross-cultural differences. But it's a bit of a messy review because of the way they're reported and in different places. But I think, so there definitely seem to be differences in the way that they're experienced. And therefore you might wonder how responsive people are to hormone therapy as well. So one thing that we know that came out from our menopause mandate survey was that hot flushes were reported most by the sample of Black women, yet they were least likely to use hormone therapy. So that's, so maybe the symptoms are highest, but least likely to have treatment. So that was interesting as well.
I think we've got some questions online.
Okay, let me go.
If we have time, we'll come back with a lot of interest, yes.
Let me go through these questions. First one, is there any benefit in staying on hormonal contraception until post-menopause, rather?
I don't really feel qualified to answer this properly. I think some people say that can help because it effectively gives you some of the hormones that you'd have on HRT. but I'd be a bit nervous about answering that because it's not really my area of expertise.
Does brain fog happen when MHT is discontinued? I.e., does MHT used in perimenopause just delay brain fog?
So I think it depends on the individual. I went on it and it stopped my brain fog and I had to come off it and it came back. But other people will be on menopause hormone therapy and still report brain fog. So I definitely think there's a link between the two, but it's not that black and white. It's not a definite solution for everybody.
And the next one, is there any research into the risks of not starting MHT early enough during perimenopause as a risk to the long-term cognition or mental ill health?
Yeah, so there's a lot of people going around at the moment saying it's high risk not to take hormone therapy, and a bit of, I'd say, a little bit of scaremongering. I think there's, so certainly in dementia, there's no clear evidence that it doesn't. Our review has showed that it neither protects it doesn't reduce or increase risk of dementia, so it's neutral. I think there is definitely in other areas of health suggestions that it might help cardiovascular health, it might help bone health. Again, I don't feel qualified to really say either way, but I think generally the advice is to go by your current symptoms rather than, it may be safer to take it based on your current symptoms rather than as a way of preventing other things. But others will disagree and say that it can be taken for prevention as well. And the science is just a bit mixed.
Got a good question here. It says, I'm a male who's received a total thyroidectomy and can relate to many of these symptoms. Is there a comparable scenario you've also identified along the journey?
Oh gosh, it's a really good question, but I'm not sure of the answer, I'm afraid. I'm really pleased though to say that, and I'm really pleased that there are some men here and there's some males in the audience, because I think that so totally not answering the question, and I apologize for that. But I think one of the really important things is that men need to be part of this conversation as well. There are male managers, there are husbands, there are sons, there are men in this, and this is affecting, so it affects men as well as women. It affects relationships. So it's really great that men are informed and also part of the research if people are interested, because it doesn't have to be just driven by women. But yes, I'm afraid I haven't come across anyone who's had a thyroidectomy, so I'm not quite sure. Sorry.
That's all for online, is it?
Yep. If we have a couple of minutes, I know there's 2 questions in the room.
Yeah, that's fine.
Yep. Okay.
Thank you so much, Aimee. It was so informative. I just have a simple question about, you had a slide, the age group for menopause was 51 to 55.
Yeah.
So if you no longer feel the brain fog, that means your menopause finish, you're into the post-menopause period? Or is the menopause period much longer than how you feel differently?
Yeah, I mean, it doesn't necessarily correlate perfectly with what's happening in your body, but I think you're more likely to have the brain fog in that perimenopause and before the menopause, and maybe a little bit after. But generally speaking, but you do meet people in their 60s who say that they still have menopausal brain fog. So, but I think generally the bit that's really, really hard is around that kind of late 40s to early 50s.
And our final question, thanks.
Thanks, Aimee. My name's Georgia. It seems like menopause is having a bit of a moment. Certainly in Australia, our last federal budget, the government funded a number of menopause-related women's health initiatives. I'm just wondering, I guess, twofold. Do you think that sense of social acceptance or people understanding or more awareness can in fact help women to get through some of these things, even in the absence of new treatments or anything like that? And secondly, what would you like to see come next from the increased awareness and acceptability in terms of what governments can do?
That's a really good question. Yes, I think social acceptance really, really helps. I've got a researcher who's done some focus groups with South Asian women in the UK who talked about, and just the sample that she had, that within their community, it's not socially accepted for many of them, and the conversations are really difficult, and they can see the differences in different kind of contexts. And I think it is becoming easier to talk about for many people, not for everybody. But how that actually translates and what the government can do, I mean, that's a really interesting question. And it came up in our discussion just before when we were talking about how lots of companies have menopause policies. I think you said there's a policy here for reproductive health. It covers sort of all stages, but do people feel it's acceptable to use those policies? That's the big question. And would it be how comfortable would I be telling my male boss that I've got really bad brain fog and I don't know what adjustments I'd want them to make? So it's a little bit vague. So I think maybe better education about what's actually happening. Like some of these figures are quite important, because sometimes it just feels like you're kind of middle-aged woman just moaning about your brain, and some men do say, oh, I have it as well. And actually explaining the link between hormones and brain health and better understanding and awareness might be a good next step. Yeah. And loads of research. I think research needs to be funded. It needs to be earmarked, because it doesn't necessarily get prioritised against other health conditions, because it's maybe not seen as critical, but it's really important. And if anyone here wants to do research and wants to ask me or collaborate or get involved in any way, please do say, because we really need more people doing it. Like there's a massive gap, and it's quite an exciting area of research to get involved in because it's a new field. So, yeah.
Great. Thank you, Aimee. And please
Okay.
join me again in thanking Professor Aimee Spector.